today about bones of the body. Start with the skull. This is a disarticulated. Articulation is just where two things come together, they're joined. So this is a disarticulated skull. His head's been chopped off. Now, Shelley here is looking a little bit better. Shelley still has her mandible. Here. This holds the lower arcade of teeth. The upper arcade of teeth is called the maxilla. We're not dentists, so we'll carry on. Here we have the rest of the skull. Now, you can break it into three regions. The facial bones, which are these irregular, weirdly shaped bones, many different names, which you'll come to in Block 3 mostly. The base of the skull, which looks even more irregular, and there's many holes and lots of things pass in and out of those holes, which you will have the pleasure of looking at again in Block 3. And then this, which is what we'll focus on today, which are the flat bones, providing most of the protection to the brain inside, so forming the skull base, the skull cap here. So we have the frontal bone on the top, first of all. To the sides we have parietal bone, parietal meaning wall. And beneath it, or inferior, we have the temporal bone, meaning time, because this is the side where your hair goes grey, first of all, apparently. And then occipital bone at the very back. So, frontal at the front, parietal, the wall on the side, temporal, below, occipital at the back. Why is it important to know this? Well, first of all, because of the sagittal suture, the coronal suture, and the lambdoid suture, connecting these bones together. So, as Dave explained in an earlier video, when you're born, this isn't fused together nicely. Your brain is growing massively, but it has a very confined space. So there's still a bit of a gap between these bony structures here to allow for expansion of the head. It forms these sutures when they calcify over. Also, we use the naming of the skulls to name the brain that it protects. So the front of the brain is the frontal lobe, the side of the brain is the parietal lobe, this lower portion is the temporal lobe, and the back is the occipital lobe. Now we'll go into much more detail about what all these structures do, and all the bits and bobs inside the brain, when we come to the neurology section, and when you're doing Block 3. So that's the skull.
Off you go. Okay, so now we're going to talk about some of the bony structures in the thorax and also the upper limb. If we start in the midline here, we see this bony structure, and that's called your sternum. Inferiorly here is the xiphoid process, here's the sternum, and above that, or superiorly, is the manubrium. And where the manubrium articulates with the sternum, here we see a little ridge, and it actually changes angle, and that's called your sternal angle. That's really important in surface anatomy. So when you're doing a cardiovascular exam and you're trying to auscultate some of the valves of the heart, you're basically going to feel here, so you're going to feel the jugular notch, you're then going to work your way down where you feel that angle change at the sternal angle, and then you know you're at the second rib, and then you know from there where you can move to find out where to auscultate the different valves. Where the clavicle articulates with the manubrium, we have the sternoclavicular joint, the clavicle itself, and here we have the scapula. So this is the a part of the scapula is the acromion. So where the clavicle articulates just means where two bony structures come together and move, is the acromioclavicular joint. If we turn Shelley around and look at her posterior view, we see the scapula. So the scapula sits on your back, behind the posterior aspect of the rib cage, and some features to point out are the lateral and the medial borders of the scapula, the inferior angle, the superior angle, and the spine of the scapula. And on here there'll be various muscles which will sit and act as points of attachment to basically move your shoulder joint around in all the different directions that it can. So if we come to the upper limb itself now, first bone we see is the humerus. This is the head of the humerus, and the neck And there's also something called the surgical neck. The surgical neck of a bone is where you're most likely to see fractures. There's various structures that run along there, and there's certain structures that are a risk when you damage that. And you'll learn about that in block 4. And then this here is the elbow, which is the humerus articulating with the radius, which moves around the outside. And in the anatomical position, medially is the ulna, laterally is the radius. We then, this action here is called pronation, and supination is turning this way. The way to remember it is if you're holding a bowl of soup, your hand comes up like that, so that's supination. The other way is pronation. So the wrist is formed of various bones. These are called your carpal bones. One of particular interest is the scaphoid. So here is the scaphoid bone, and it's quite a bad bone to break because it's at risk of something called avascular necrosis. So it's got a blood supply which comes around here and then works its way back. So if you fracture it distally, then you're at risk of the bone not having blood supply at this proximal aspect, and it actually the bone dying or becoming necrosed. Then we have our metacarpals and our phalanges, proximal, middle, and distal phalanges.
Right, let's talk about the vertebral column. This long thing at the back. Support, shock absorbing, protection of your spinal cord and those nerves that are so important. So, we have different regions. This region, where the neck is called the cervical region. This region, where the thoracic cavity is called the thorax, the thoracic region. Then we have the lumbar region. Then we come to the sacral region, and finally the coccyx down here. Now your sacrum and your coccyx are fused vertebrae. They used to look like this in evolution, and they still do in many species. But with us, they're fused, they are fixed. This is the sacrum. It has 5 different vertebral bodies fused together that still have the holes for the nerves to pop out of. So we'll get rid of that. So, as I said, cervical region. There are 7 cervical vertebrae. You can count them. 1, 2, 3, 4, 5, 6, 7. What are they noted for? Well, they're noted for having what's called a bifid process here, which means 2 points. So whereas these have 1 long point, they're noted for having bifid ones. Obviously, that's highly variable. The thoracic region here, there's 12, and they look like they've got long snooty noses because their spinous processes here slant downwards, like this. And this is, because if they just came out, there'd be loads of holes along here. So any sort of penetrating injury, such as a stab wound or falling and any kind of fracture or injury, could get straight in this vertebral column to your spinal cord, which is underneath here and needs to be protected. So this is sort of like links in the chainmail. The lumbar region is absolutely huge. It's just massive. These are big fat things because their job is to support the body and to take all of the weight. The further down you go through this column, the bigger the bodies of the vertebrae need to be to support an increasing amount of weight. And then we've already said the sacrum and the coccyx is right there. So this rib cage here protects the thoracic viscera. Viscera just means entrails, it means the organs within. So you've got lungs here, you have the heart, you've got the right ventricle of the heart sat right behind the sternum here. So the sternum, Dave's already spoken, you've got the manubrium, the sternal body and the xiphoid process. You have these cartilage. This cartilage is a bit sort of like, it's a point, it's a structure that holds together 2 bits of bone. So what you have here is the sternum, you've got the ribs, and you have a whole cluster of ribs. You have true ribs that articulate directly with the sternum. You have false ribs further down. See this one here? This rib doesn't articulate with the sternum. It's not one of these things. It articulates with this line here called the costal margin, which is just an elongation of costal cartilage. So these ribs here that don't have their own discrete connection to the sternum are called false ribs. But there's two more if you look inside. It might actually be more accessible at the back. So, ribs 11 and 12 here are called the floating ribs because there's muscle that surrounds them, and if you note, they don't articulate at all with the sternum. They don't even have costal cartilages at the end here. They're completely floating ribs. Now, how are some of these structures important and why do we care about them? Well, actually, as it happens, your kidneys are floating here. They're floating about here. In fact, this is the level of L1. And why do we care about that? Well, it's because that's the point at which the artery goes into the kidney to supply it with nutrients, and the vein comes out, and the ureters drop out for urine production to be moved to the bladder, which we'll come to in the urinary system. But if you find your 12th rib, which is a nice bony bit, and if you find the vertebral column, here, this is where your kidney is. So you can put a hand here, you put another hand here, and you push between the two, and that's called balloting the kidney, and that enables you to see whether the kidneys drop down, if it's in place, if there's any irregularities. At the front here, our costal margin is used because this is the inferior most point of where your liver should be. Let me grab a liver. If we pop a liver in here, this is where the liver is. So actually, you can tell the patient, take a big breath in, lungs fill. As the lungs fill, they're here, they push your liver down just at the costal margin. So if you get your hand and go, whoa, like that, you should be able to touch the edge of the liver. Now, if the patient's got a breath, takes a breath out, and the lungs shrink so the liver can rise up, you shouldn't be able to feel the liver at all. If you can feel the liver, it's either dropped or it's much bigger, which can be a sign of liver cirrhosis, liver failure. So then you would have to investigate in other means and look for other signs of liver failure. So that's your ribs, quick overview of the sternum again, and a very brief introduction to the vertebral column.
So now we're going to talk about the pelvis, which is here on Shelley. And if we just grab this model here, so this is the bony pelvis, and some landmarks to note are, so the joint here between the sacrum, which Dan mentioned before, the fused part of the vertebral column, and this bone here, which is called the ilium, is the sacroiliac joint, and that can dislocate. And then if we move on, there's three bones here which fuse together to make what's called the acetabulum. So the acetabulum is the hole into which the head of the femur articulates, and we can flex or extend the leg, and we can abduct. So these are a couple of new words: abduct and adduct. Imagine the word absent meaning away, A-B, abduction moving away from the midline, adduction moving towards the midline. Some other bony landmarks to notice on the hip here. This is the iliac crest, and you can feel these on yourself. If you push in here, it's a flat point of the hip, and it's an important landmark in surface anatomy because it sits at L4, and that's used particularly by anaesthetists to locate which vertebral body they're at, and so they know where to put any anaesthesia or injections they're injecting into the person. And then here we have the anterior superior iliac spine, which is known as ASIS, and this prominence here is called the anterior inferior iliac spine. Again, the pubic bone and the ischium, the three bones forming the acetabulum. If we move a bit more around towards the midline anteriorly, we see a bit of cartilage here, and that's the pubic symphysis. Similar piece of cartilage to what we find between the vertebral body, so the intervertebral discs, and one of its functions is to work as a shock absorber. Again, particularly in pregnancy, that can be affected by hormones. An example is relaxin. You'll learn about that in block 5, and this can dislocate. So the two halves of the hip can actually open up, and it's called an open book dislocation. And here, this bony part of the hip which you sit on, again you can feel on yourself, it's the part that you rest on is called the ischial, because it's part of the ischium bone, is the ischial tuberosity, and ligaments connect between the sacrum to these bony landmarks. So this one here is the sacral spinous ligament, and the one here to here is the sacrotubral ligament, and they form. So the ligament will run. So the sacral spinous ligament will run across here, and as you can see above my finger there's a hole there through which certain structures will run through. So this hole here is called the obturator foramen. So it's called the obturator foramen because the obturator nerve runs through it. Foramen just means hole. Like Dan mentioned before, there's foramen in the skull, and there's a foramen just means a hole. So the obturator foramen is where the obturator nerve runs out. It supplies the medial compartment of the thigh, and it lets you adduct. So there's muscles which will be innervated by that nerve, and it lets you adduct. So bring your thigh and your leg in towards the midline. On the back, the last thing to note is these bony prominences here, which is the PSIS. Again, an acronym which stands for the posterior superior iliac spine, and again, another on surface anatomy, you can often see these, and they're colloquially known as the dimples of Venus.
So we have the femur, and we have this is the femur, which means thigh. Femur means thigh, so this is the thigh bone. It's the largest, strongest bone in your body. If a patient presents to you with a query fractured femur, then the mechanism of injury that has brought them in is probably quite severe, and there's going to be a lot of other things going on. Femur. The femur here is articulating with this wee bone here, called the patella, or your kneecap, as it's more colloquial known. Then we have the tibia, the shin bone, very superficial. You can feel your tibia immediately with no issue. This is the medial structure with the fibula lateral. So make sure you can orient yourself when we come to the tibia, the fibula, the medial and lateral, and when we come to the upper limb, or the radius being lateral. This is the vital nature of the anatomical position. Okay? So, tibia, fibula, and then we have the foot. So the foot is composed of a few different things, but we'll get to that. So let's start with the femur. So this is the anterior view of the femur. This is the posterior view. I don't know if you can tell, but the anterior view is much smoother. And that's because there's a whole collection of very powerful muscles that attach to the back here. And they create this big ridge here, which is called the linea aspera. Now, we'll stay at the back. So you have a big bit here and a big bit here. This is called the greater trochanter. This is called the lesser trochanter. This is the neck of the femur, and this is the head of the femur. So again, let's remember that the head of the femur points medially. So we should have a certain angle of the femoral head and neck in relation to the shaft of the femur. If this angle is increased or decreased, it will cause bowing or knock knees. Yeah? So bowing, legs out, or knock knees in. So this is very important, and the stresses applied through development or malnutrition or any kind of changes, malignancy and the like, can cause severe deformities that require correction if you still can as early as possible. Here's your femur. Shaft. And then at the end here we have these bony protrusions called condyles, 1 and 2. And the condyles articulate with this round structure here to this bit, the tibia. This is the tibial plateau. So you can put the two together like this, and they will roll over each other to flex the knee joint, with the patella providing stability and support for the muscles. So this is the tibia. It's called the tibial plateau, and in between this region here is the intracondylar eminence. Now what does that mean? Let's break it down. Eminence because it's a bump. Yeah. Intra means between. Condyles, these femoral condyles. So this is the intracondylar eminence between femoral condyles, allowing this rolling action to occur. And a locking in place of that knee joint for stability. So you can imagine what happens with the full weight of your body being transmitted through these joints if you have unstable bones at the knee here. Likewise, there's a little covering of cartilage, it's called hyaline cartilage, that protects these two joint surfaces. How much do you think this happens in your lifetime? Flexion, extension, rubbing between bones. How easy would it be, with all that weight and force applied every time you take a step, for these bones to knock up against each other and damage each other? So the vital nature of the cartilage sort of underscores what happens when you don't have it. And arthritis, in particular osteoarthritis, is a classic example of this. So, let's stick with the tibia. So, the front of the tibia here is the tibial plateau. Now this, tibial plateau, and then you've got the tibial tuberosity here. Now this tibial tuberosity is a giant bump that again you can feel on yourself at the top of your tibia, at the top of your shin. And it's seen here. This is where these muscles here, which you may have heard before called your quadriceps, your quads, they come down and they grab the tibia, when the knee's in flexion, they grab this tibia and they yank it backwards, like this, to do that movement. So muscles come from up here, they run down, they grab the tibia, and then they will pull up and back to cause a powerful kick, a powerful extension. What else have we got? So we've got the tibia here, and this will articulate with the foot here, and structures that you'll get to in block 4 in more detail. This is the fibula. This is not so much a weight-bearing bone, this is more for the attachment of muscles. You have a head of the fibula, neck of the fibula. This is also very superficial, it's liable to fracture, and some very important nerves run very close to the skin surface, right around the edge of here, which means that if you fracture this head, then you'll get a classic sign where these nerves don't work, so very certain things distal and inferior to this point will not receive their nervous supply, which means they won't receive the information from up top here to do things, so they'll become paralysed. Now we come to the foot. So, the foot can be divided into a couple of regions. I'm going to keep it very simple. These big bones at the back are called your tarsal bones. Then you have your metatarsals, which are this region here. And not to be confused with the metacarpals in the hand up here. Metatarsals and then phalanges. So you have phalanges in your hand, and you have phalanges in your foot. And that is the lower limb.